I want to thank ECHO for this collaborative opportunity to discuss mental health and Prader-Willi syndrome. The information in this talk is derived from my 30 years of experience, together with my colleague, Dr. Linda Gorosh, the other part of the Pittsburgh partnership, and also my good fortune to have had some clinical research avenues defining cognitive and behavioral phenotype, recognizing and mitigating parental stress, and understanding how pharmacogenomics in Prader-Willi syndrome helps us understand our individual's extreme sensitivity to psychotropic medication. I want you to know that in this presentation, I'll be making some generalizations based upon considerable clinical experience, dealing with patients of all ages and of all levels of severity. And please keep in mind that although persons with Prader-Willi syndrome have similar characteristics that allow us to make the diagnosis, they are also dissimilar from one another. And one of our tasks as clinicians and researchers is to try to understand why. So the learning objectives for today: to describe the longitudinal course of phenotypic behaviors, to understand psychiatric symptoms as distinct from the phenotypic behavior and also stress response, and to discuss an algorithm for intervention that highlights eco-environmental modifications, strategies for improving coping skills, use of behavior therapy, and management with psychotropic medication. So slide 3. I'm going to give some definitions. We've spent a year in the mental health workshop sort of defining what mental health is. It is a state of psychological well-being and contentment, and mental ill health is a feeling of dis-ease or feeling unwell that is unique to each person. But psychiatric diagnosis is based upon a set of clinical symptoms that occur over a specific duration of time that interfere with level of function. And level of function is, in fact, the day-to-day mood, behavior, and cognitive capacity attained by the person with Prader-Willi syndrome prior to the onset of symptoms and change of function. And then eco-environmental is a behavioral term that really defines the environmental context that is specific to the management of phenotypic behaviors. And we'll talk a little bit more about that. So for all of us, we are all a product of our genes, and for Prader-Willi syndrome, it is no different. Individuals with PWS are missing the expression of paternal genes from the critical region on chromosome 15, either by paternal deletion or by maternal uniparental disomy. Those with UPD are missing the paternal genes, but express more genes from the maternal chromosome. Both genotypes are static across development. Okay. So that was interesting. So the phenotype does predict behavior in Prader-Willi syndrome, but the phenotype is somewhat dynamic. And that's one of the most amazing things about Prader-Willi syndrome, because there is a change across the developmental life cycle. And I've used an example of the nutritional stages in Prader-Willi syndrome, where our individuals start with failure to thrive in infancy, and then have increased weight without caloric change, and then increased interest and reward from food, which in the absence of satiety leads to obesity. But food is just the tip of the iceberg in Prader-Willi syndrome. What we know is that as the brain develops, the other phenotypic behaviors related to cognition and behavior change as well. So this schematic looks at the phenotypic behaviors that we see in Prader-Willi syndrome across the lifespan, starting in infancy and working their way up to middle age. So for all of us, behaviors emerge as the brain matures. The behaviors of young children with Prader-Willi syndrome are similar to those displayed by typical children once they get out of the hypotonic phase. Behaviors such as insistence on sameness, body-focused repetitive behaviors, and repetitive questioning are early coping strategies used by the typical child to master anxiety and adapt to events that they can't predict or cannot control. In typical children, these behaviors diminish as they learn more adaptive skills to manage their anxiety. But in the child with PWS, these behaviors are more intense, The developmental shift occurs much more slowly, and old behaviors are more likely to be retained rather than extinguished. Coping strategies don't occur automatically, and if they do, they rarely generalize. So for progress to occur, skills must be taught in real time within each context with reinforcement. For the child with PWS, repetitive asking about events, not food, occurs as soon as they can talk and reflects their anxiety or uncertainty around expectations or what will happen next. The first tantrum is associated with disappointment, that is, when what is expected doesn't occur, and it reflects the underlying maturation of the reward center of the brain, which is the orbital frontal cortex. Interest in food occurs around the same time, and repetitive questions in tantrum increase steadily throughout childhood, peaking around age 8 to 10. They continue at high rates and intensity throughout the adult years. And although children never outgrow their behaviors, there may be some aspects of functioning that do get a little bit less in the middle age of their lives. And that would be the repetitive asking and also some of the food-related behaviors and some of the tantrums. And that is what Elizabeth Dykins has referred to as mellowing. These are the domains of the Prader-Willi personality. We've developed a questionnaire called the acuity scale. The first part of that does go over the domains of the phenotype. And this questionnaire looks at when behaviors start, when they begin to have a problem, and then also what their level of severity is and how much they interfere with level of function. So this gives us a very interesting look at how these phenotypes change over time. So the phenotypic behaviors such as tantrums, cognitive rigidity, and excessive repetitive behaviors and skin picking are the ones that often come to the attention of the mental health clinician. These behaviors are a manifestation of the phenotype, and it's what we call the the personality change secondary to PWS. They're best addressed by eco-environmental interventions that are tailored to meet the individual needs of the person. And today we talk about precision medicine, but we think what works best in Prader-Willi syndrome is a personalized precision environment. So what we know is that loss of expression of paternal genes in the critical region on chromosome 15 are related to stress sensitivity. And it's really a difficulty adapting to the environment that is determined both biologically, psychologically, and socially. Both stress sensitivity and adaptability deficit are mutually interrelated, endure lifelong, and predispose to other psychiatric disorders. And so I like looking at ADD, not attention deficit, but adaptability deficit disorder in our individuals. Although both the PWS genotypes share stress sensitivity and difficulty with adaptive behavior, there are differences in the neuropsychiatric phenotype. I know this is a very busy slide that contrasts aspects of both the paternal deletion and the maternal uniparental disomy, but I want to highlight some aspects of this. Among those with the deletion subtype, the size of the deletion does seem to have an impact on intellectual function, learning challenges, and excessive and repetitive behaviors. I want to bring to your attention that shape discrimination capacity seems to be almost at a savant level in individuals with paternal deletion. It makes them really good at solving jigsaw puzzles, but it also makes them incredibly great at assessing the social hierarchy in interpersonal situations. They will always go to the person who has the highest power. And the other aspect of that ability is their capacity to pick up bits of information that they hear from others in their environment or that they watch on media or TV, and they incorporate these bits of information into a personal narrative, which seems seamless and personally relevant to them, but may be very distorted and completely false. So I think it's important to understand how our folks use the information in their environment to create some of the difficulties that they have interpersonally. Also, people with the paternal deletion tend to have more difficulties with depression, with or without psychosis, as they age. So this can start in adolescence and persist throughout adulthood. Now, the individuals with maternal uniparental disomy are different. They have a higher verbal IQ. They have sort of a nonverbal learning disability phenotype with greater auditory processing capacity compared to visual. And they have a tendency to have symptoms of autism spectrum disorder, but they rarely meet the diagnosis for autistic spectrum. But I do want to mention that there are a group of individuals who manifest early in development. They are nonverbal. They have a high rate of stereotypies. They do not display food seeking, and they do seek social proximity. And they do meet the diagnosis of ASD, and they are very different from other individuals with PWS, and it is a small group. Our individuals with UPD tend to have the acquisition of bipolar affective disorder with or without psychosis in the late adolescence and early adult years, such that at this point, about 65% of people greater than the age of 30 will convert to have this diagnosis. Cyclic psychosis is also prominent, and there is a question of dementia. There are some papers out there that suggest that our individuals may have problems with dementia, particularly with uniparental disomy, but I think that that is not necessarily the case, and we need more studies to look at that. So these schematics really look at the effect of stress on a person with Prader-Willi syndrome. So think of that Prader-Willi personality, the baseline phenotype, as a person with good level of function. And as you increase stress, and the stress can come from inside or outside, so that increase in stress causes an increase in intensity of typical behaviors. And then when the person's ability to cope comes in conflict with what the environment considers as normative behavior, then their behavior becomes maladaptive. And then as the stress increases, the coping strategies that the person have diminish. And then the person is coming to psychiatric evaluation. So the most important part of the there are many, all of the parts of the psychiatric evaluation are important, but the history of the present illness is usually obtained from the carer, not the person, because our guys don't have a good sense of time and time passing and when symptoms are associated with stress. So we do this from the carer, and we also look specifically for a functional change in their level of change. Look for a change in their eating, sleeping, mood, goal-directed behavior at school, at leisure, and at work. So in my practice, while this is happening, a screening test, either a depression inventory, a draw a person test, or items from the Montreal Assessment of Cognitive Function, and the person can do that independently in the waiting room. And then the diagnostic interview is with the person, and most definitely the person alone, and it really showcases the person's view of their situation from their point of view. It also establishes rapport, because this diagnostic interview is often the beginning of a long-term relationship with the individual. They may talk about the anxiety related to uncertainty, about things that will occur. They will complain about others not doing things as expected. They will talk about conflicts with peers, and a variety of somatic concerns. On the mental status exam, I think that assessing thought content is the most important. And if this may be abnormal with referential thinking and fixed ideation that could reflect fantasy, what the person wishes might occur, it could reflect that knitting phenomenon where they take information from other sources and integrate it as part of their episodic memory, which is false, or it could be delusional. Thought process may be digressive, egocentric, and there may be significant processing delay. And I can sometimes ask a question and just count to myself 1001, 1002, 1003 before the person responds. In the classroom, this is most often assumed by the teacher to be noncompliance. And it's really that the person has not assimilated the cue or the demand. And it causes a great deal of frustration for the person and also for the teacher. Insight into behavior is very limited, and they may also say what they think you want them to say. And I often ask, what is Prader-Willi syndrome? And I get some very interesting answers. Many people today will say it's an eating disorder, but some people will say, one person said in the past, it's a food deficit disorder, which is my favorite. So always remember that the environment is the shadow patient in the psychiatric evaluation. And you need to ask yourself, is there a goodness of fit between the person and the environment? Or is there a difficulty where the person's needs exceed what the environment can provide, or that the environment is expecting way too much from the person? And both of these situations related to faulty infrastructure lead to the expression of maladaptive behavior. So the case formulation is essential, and that depends on the genotype first and foremost. As we know, there is a difference in the neuropsychiatric phenotype based upon that genotype. The age is important. The IQ and developmental level is important. What we know about our individuals is that the average IQ is about 65. And you need to be aware that the intellectual capacity is rarely commensurate with judgment or emotional function. So their emotional quotient is significantly less, and measures of adaptive function do not necessarily improve with age. There may be learning differences that we've already talked about. We want to assess the person's match between their needs and their infrastructure in which they live, and the person's life experience and their expectations for what will happen on a daily basis, because this is likely to fuel behaviors. We always want to find out about what's in the family, because those genes are also expressed in Prader-Willi syndrome. So if a person has a strong family history for OCD or affective disorder, that will be important. And then sources of stress are essential. These are usually the precipitating factors. Perpetuating factors are often interpersonal difficulties and, like I mentioned, the insufficient infrastructure in the environment, and also protective factors. Our guys do develop coping strategies. It's just that their coping strategies may bring them into conflict with what we are all expecting. But we need to find out what they have available to them so that we can build on those. So the psychiatric diagnosis, in a very simple kind of way of looking, is the PWS personality under stress, what I call PWS plus, which is a psychiatric disorder, a learning disorder, medical disorder, or an iatrogenic etiology, which we'll talk about in a minute, or environmental insufficiency. So this is a list of diagnoses. The first 5 diagnoses are likely to occur more in younger patients. Older patients may present with anxiety and dysthymia, which are often traveling companions. And keep in mind that COVID led to unwelcome restrictions to people's lives, with decreased work opportunities, decreased opportunities for social interaction, and loneliness. So anxiety and dysthymia are well represented among diagnostic categories. Depression is sadness, persistent sadness, low energy, low interest, low motivation, critical or self-depreciating thoughts, and we always have to assess for suicidal ideas and plan, and the person may have psychotic features to their depression. Bipolar disorder is important for the mania, which presents with elevated mood and irritability. Some people may just be silly. Increased energy, decreased sleep, impulsive behaviors with a high risk for negative outcome can be seen. And by definition, with bipolar disorder, whether it's manic or depressed, there is usually psychotic features associated with this. There is also hypomania, which is less likely to have psychotic features, but may have all the increased goal-directed behavior and energy associated. Then there is mood and behavioral activation, which occurs usually with medications of SSRI type, and it appears at greater than typical starting doses of these medications. So that doesn't say that SSRIs shouldn't be used in Prader-Willi syndrome, because it may help modify some of that rigidity and stress response, but too high doses are going to cause the gradual onset of irritability, intense tantrums, and impulsive self-injurious behavior, which is out of character for Prader-Willi syndrome. This is stabbing, cutting, jumping out of a vehicle, jumping over a railing in a mall, grabbing the steering wheel, or jumping out of I mentioned jumping out of a moving, grabbing the steering wheel of the vehicle, or trying to press the gear shift. These are uncharacteristic for Prader-Willi syndrome, but very dangerous, and often will come to attention, but it's the gradual onset that separates it from some of the psychiatric diagnoses. And then psychosis is acute onset. Usually it can be delirium-like. It can present with motor symptoms. There is sensory hypersensitivity, delusional thinking, oftentimes paranoid, sometimes with persecution, and sometimes with somatic delusions or preoccupation. You need to take me to the emergency room. I feel unwell. There can be hallucinations. Most times when people are psychotic, they stop eating and they have a loss of ability to groom. And this presents a picture of confusion. And the person who usually was able to automatically go through all of the grooming activities, such as getting up, washing your face, brushing your teeth, getting dressed, they require cue-dependent lists of what they need to do next, and people, they're cueing them verbally to help them get through the list of ADLs. This is a very significant departure from what typical function is in individuals. Okay, so I just want to mention that I don't have OCD up in this picture, in this look at diagnoses, because I think that people will talk about obsessive compulsive behaviors in Prader-Willi syndrome, and the literature commonly associates it with Prader-Willi syndrome. But I think that the phenomenology of food preoccupation, body-focused repetitive behaviors, repetitive questioning, need for sameness, hoarding and ordering behaviors, and other excessive repetitive behaviors are unique to the syndrome and do not cause person's distress. In fact, I think it probably is a way of managing anxiety. In the past, labeling these phenotypic behaviors as OCD has led to treatment with high doses of SSRIs, which is what you do in typical individuals who have OCD. But in our individuals, greater than typical starting doses often cause mood and behavioral activation. So interventions. I'm going to present this PWS pyramid, intervention pyramid, simply because the environmental interventions that we are talking about here are the eco-environmental medications to manage many of the phenotypic behaviors that we see in Prader-Willi syndrome. And that includes outbursts, because they come from a lack of ability to predict what's going to happen next, or disappointment in expectations. And all of these things are managed when you use the train. So the train is an eco-environmental tool that reduces syndrome-specific behaviors by managing the interaction between the person and the environment. And these are the elements of the train. When you're loading your train and queuing up all of these items that occur through the day, you start with meals and snacks, and then add hygiene and grooming activities, punctuate that with school and work activities. Exercise is hugely important, not only for weight regulation for individuals with Prader-Willi syndrome, but also for stress management, and also helps some of the sleep-wake difficulties that they have. Sensory needs are lifelong. Sensory needs are lifelong and are also integrated into the train. Chores are important because they are non-preferred activities usually, but they are essential to the person's level of function through the day, as are leisure skills. Leisure skills are very important to our folks with Prader-Willi syndrome, and sleep is also essential, but I want to limit daytime sleep because it interferes with nighttime sleep. You can find a monograph on how to implement the train on our website, www.pittsburghpartnership.com. So what makes the train special is that it is a linear daily schedule. It alternates between preferred and non-preferred activities, which sort of helps the flow of the day, which also results in a feeling of psychological well-being. It provides predictability, it minimizes uncertainty, and it provides continuous feedback to the person. It achieves a balance of tasks and activities. Many of our guys, during COVID, would just do the same preferred activities for hours during the day. And it did not help them with their self-esteem or with anxiety management. And it certainly didn't help with mood because we know that the train sets and reinforces Zeitgebers, and Zeitgebers are essential in typical people for managing mood disorders. So these are the time when you eat, the time when you exercise, the time when you sleep. These are very important to mood stabilization. Food security is also an element of the train. This is the person knows what they will eat, how much they will eat, when they will eat it, and when they won't. Food security manages both food and behavior for the person with Prader-Willi syndrome. Without food security, the person constantly battles with their expectations, which inevitably lead to disappointment and tantrums. Food security, not FOD, food security puts a lock on the thought. And when the person is not constantly thinking about food, they can use their mind for other things. And so what we find is using the train, where everything has its beginning, everything has its end, and everything is time limited, you end up with everything security, which helps the person with PWS. So the next item on the pyramid is coping strategies. Teaching appropriate behavior in context is important because our guys in general have poor generalization skills, and then reinforcing with praise is essential. We want to teach adaptive replacement behavior. We want to use for repetitive questions, for example. We want to use scripted conversational skills. For intrusive hugs, we want to use handshakes or fist bumps. We want to use relaxation training for addressing anxiety. All of these are scripted, rehearsed, and cued with the person. And I consider this a benefit not only for the person with PWS, but also for the carer, because when they're doing it with the person, the carer is also reducing anxiety, because as we know, anxiety is huge in parents. Also individuals that are responsible for the care of people with Prader-Willi syndrome, and even administrators in programs or in schools that are managing people with Prader-Willi. Anger management strategies can be taught to our folks, and social skills can be taught. There's a great curriculum out there that was done by Elizabeth Ruth through Foundation for Prader-Willi Research, and it's called the BOSS curriculum for social skills. And you can use social stories with natural consequences, and most certainly do an apology for inappropriate behavior. It may not prevent the behavior from happening again in the future, but it is an appropriate social skill to do for the person, especially for the carer. And then, as I mentioned, to teach adaptive escape and avoidance behavior for the person. Just very quickly, incentives or contracted reinforcement is very easy to add to the train. A person who is depressed may benefit from decreasing the density of activities or increasing time with preferred activities, and may benefit from incentives. And the second is behavior plans. A lot of information here, but basically it adds to the infrastructure. It further individualizes the daily plan, and it's best implemented with the consultation from a behavioral therapist. So here's the top of the pyramid. When do we use psychotropic medications? And all of this can be reversed if, in fact, when you evaluate the patient, you see that they are acutely psychotic, and you need to treat the underlying psychiatric disorder, and it may be on an emergency basis. Meds may be used to augment the effectiveness of other therapies, and they may be used to manage a crisis. So what in fact do psychotropic medications do? This is not just in Prader-Willi syndrome, but they can modulate the stress response, and that would decrease the person's response and interaction with the environment through the use of dopamine blockers, such as neuroleptics, or GABA agonists, such as anti-epileptic drugs, benzodiazepines, alpha-adrenergic agonists, beta blockers, SSRIs, antihistamines, and lithium. They also modulate the reward drive. We think that the reward drive is enhanced in Prader-Willi syndrome. And so we want to increase the response and interaction with the environment to optimize learning. And that is through the use of stimulants, norepinephrine and dopamine agonists, and also sometimes opiates. So with respect to pharmacotherapy in PWS, there are no medications that are given because a person has Prader-Willi syndrome. And there are no medications that can't be given to a person that has Prader-Willi syndrome. But all medications must be used with special care. Start low, go slow. Try to make one medication change at a time. Try to use short-acting medications first. And please check into my chapter in the new management book on pharmacotherapy in Prader-Willi syndrome. It has all of these issues related to how to use medications adaptively in PWS. So I want to show you my bucket. The bucket is basically the environmental containment vessel. This is the bottom of the pyramid. And if you don't have a good infrastructure for your person with Prader-Willi syndrome and they're presenting with symptoms, you may be tempted to use medications. And the medications go into what we call a leaky bucket. And so the medications then precipitate side effects where they don't work, so you increase the dose. And because there are additional symptoms or side effects that occur, you add additional medications. And before you know it, you have drug-drug interactions and a hot mess. And so this is the reason why the environmental structure is so important in Prader-Willi syndrome. The neurochemistry is different in Prader-Willi. So we know that the serotonin receptors are deficient with a bias toward activation through 2A versus inhibition through 2C. We know that the serotonin receptors they come online at different ages, so that they are biased toward activation through the developmental period, and don't even up until adulthood, and then even after adulthood, activation is greater than inhibition. So it places all of our individuals at risk for mood and behavioral activation when you use medications that involve a serotonin receptor. GABA receptors are deficient. GABA is the whoa, wait a minute neurotransmitter in the brain. And our guys are deficient. And not only are the receptors deficient, but GABA itself is deficient in the PWS brain. And we now know that dopamine transporter is hypomethylated, which may have significant implication to the reward drive in PWS. So I want to call your attention to the paper Pharmacodynamic Gene Testing in PWS, because it has all of these issues related to neurotransmitters delineated in PWS versus typical. And then I also want to bring your attention to the pharmacogenetic testing article that we did. There were 14 individuals with deletion and 16 individuals with UPD. And we found that the cytochrome P450s, which are responsible for the metabolism of medications in the liver, are the genes that code for these are different in Prader-Willi syndrome. And that difference does depend upon whether the person has deletion or UPD. So what we found was that cytochrome 2d6, which is really one of the powerhouses in the liver for metabolizing psychotropic medication, it is more, let me just mention on the left side of the screen, you'll see ultra rapid metabolizer, extensive metabolizer, which is normal metabolizing. Intermediate metabolizer is sort of middling, but less than extensive, and poor metabolizer means that low doses and decreased frequency of dosing through the day may be required. These differences don't mean that the medications cannot be used. They just have to be used with greater care and supervision. So in PWS in general, more people have poor metabolizing status of cytochrome 2d6, and I'll just give you a list of medications: amphetamines, aripiprazole, chlorpromazine, citalopram, clonidine, diphenhydramine, that's Benadryl, which you use for managing sleep and some side effects to the neuroleptics. Escitalopram, fluoxetine, fluvoxamine, haloperidol, olanzapine, paroxetine, propranolol, quetiapine, risperidone, thyroidazine, trazodone, venlafaxine, ziprasidone. All these medications are metabolized in a significant way through 2d6. All of these may be affected whether the person has deletion or UPD. And if you have any question, I mean, this is broad generalization, but get the pharmacogenomic testing on the individual so you will see whether they're sensitive or not. It is particularly critical in people with deletion who have 50% fewer extensive metabolizers, and also 25% more intermediate metabolizing. So the two others are sort of like cousins. Cytochrome 2C19, we see that deletion is shifted upward toward increased metabolizing status, whereas UPD doesn't have that similar picture. And then the opposite is true in 2C9, where deletion is typical and the UPD is shifted downward with decreasing metabolizer status. We do not understand why the genes have assorted this way. Hopefully, we'll be able to determine that in the years to come. We do know that cytochrome 3A4 is the enzyme that metabolizes growth hormone. So drug interaction may be seen because PWS as a whole tends towards slower metabolism through this cytochrome. And 1A2 is interesting because it is the only cytochrome that is located on chromosome 15. So you would expect that individuals with a larger disomy condition in UPD may have more polymorphisms of this particular gene, and that's in fact what we saw. What we did see was that individuals with deletion have more extensive metabolizer status and the inducible polymorphisms of cytochrome 1A2. And by inducible, it means that when you have a person who is on certain medications or uses certain things like caffeine, that there may be an increase in the metabolizing status. And so to give you some indication that tobacco, char grilling, and also cruciferous vegetables, which are like cauliflower and broccoli, those kinds of things all are subject to inducing this enzyme, which can have an impact on medications like acetaminophen, fluvoxamine, olanzapine, haloperidol, and others. So I want you to understand that what I'm proposing is this eco-environmental intervention is a restrictive intervention for individuals with Prader-Willi syndrome, but their level of function can be improved so when we use it. And so there's always this balance, which I've set on the intervention pyramid here, because we do want to respect personal rights and choices, but we also want to give the person the opportunity for the best possible outcome. So I want to thank you very much for your attention. Please check out our website. We have lots of monographs available. Some are in Spanish speaking. section that we have. And please, if you have any questions, email me. I am available. And if you're interested in the acuity scale, I can provide that to you. Thank you.